Welcome to the second part of the presentation on atherosclerotic cardiovascular disease, which focuses predominantly on the pharmacological therapies used in disease prevention and progression. In this short presentation, I hope to provide an outline of the most important medications used, starting with those that directly impact upon plaque formation, the cholesterol-lowering therapies and the antiplatelets. I will also outline the other important medications which often go hand in hand with managing conditions associated with atherosclerosis such as angina and hypertension. A brief summary of recent UK guidelines for these conditions will be given, and below are some of the generic names and abbreviations of medications that will be mentioned. There are many medications that lower cholesterol, and this table provides an idea of the impact that 3 of the more common agents have on the lipid profile. It is useful to see how we may want to target a particular lipid, for example, treating someone with hypertriglyceridemia with a fibrate and not a statin. Patients often ask about their cholesterol and what normal is, but in practice no one such value exists. Treatment strategies are based on either primary or secondary prevention and cardiovascular risk profile as a whole. Equations such as the Framingham 10-year risk equation can be used to identify cardiovascular risk and guide treatment. Statins competitively inhibit HMG-CoA reductase, an enzyme involved in cholesterol synthesis with the effect of decreasing low-density lipoprotein in the plasma. They are traditionally prescribed to be taken at night time to maximise their effect because this is when most cholesterol synthesis occurs. The 2 most important adverse effects to be aware of are firstly statin-induced myopathy, which covers a range of conditions from myalgia and asymptomatic rises in creatinine kinase to myositis and rhabdomyolysis, and secondly hepatotoxicity, which is thankfully rare and usually reversible on cessation of treatment. Further advice on initiating statin treatment can be found in the links at the end of the presentation. Antiplatelets play a key role in the prevention and progression of atherosclerotic disease because platelets are crucial to hemostasis, and because of this, antiplatelets are most effective at preventing arterial thrombi. With regards to starting patients on such medications, I again refer you to the NICE guidance, but in general, secondary prevention of cardiovascular disease, acute ischemic events and atrial fibrillation are the most important indications. The main contraindications for these agents is risk of bleeding, therefore should be avoided in those with active peptic ulcer disease or uncontrolled hypertension. This slide summarises the NICE guidelines for management of hypertension. As we know, hypertension often coexists with atherosclerotic disease, and reducing high blood pressure can help reduce the risk of adverse cardiovascular events. Again, use of equations to formulate cardiovascular risk are helpful here. Once we have identified and elected to treat hypertension, the management is dependent on race and age. One reason for this is because of the subtle differences in underlying pathophysiology, with black patients having, in general, a lower plasma renin activity than Caucasian patients. By stage 4, specialist advice should be sought. For angina, beta blockers are first line, combined with a calcium channel blocker if no improvement. Additional agents such as a nitrate, ivabradine, nicorandil or ranolazine can be used for additional symptom control, but only when the patient is awaiting revascularization or it has been decided that this is not appropriate. Of course, providing there are no contraindications, patients should also be started on aspirin and a statin, and a GTN spray given for acute attacks. ACE inhibitors act renally to prevent angiotensin II formation and increase salt and water excretion. Angiotensin II is a powerful vasoconstrictor, and its inhibition therefore lowers blood pressure. A dry cough is common with these medications and for some may be intolerable. As such, angiotensin II receptor antagonists can be substituted. Important considerations to note are that angioedema is a rare complication which can occur even after long-term use, and that renal impairment can occur with ACE inhibitors in the setting of renal artery stenosis. Therefore, renal function must be monitored after initiation to detect subsequent renal failure and hyperkalemia. Beta blockers competitively inhibit catecholamies, which act at central and peripheral receptors. The beta blockers have different properties, with the most cardioselective, i.e. predominantly beta-1 effect, being atenolol, bisoprolol and metoprolol. Beta blockers are, not surprisingly, contraindicated in asthmatics, unstable heart failure, and should be avoided in peripheral vascular disease. The three main classes of calcium channel blockers are, firstly, dihydropyridines, which are nifedipine and amlodipine. These act on vascular smooth muscle and therefore do not affect myocardial contractility and are useful in hypertension. Then we have the phenylalkylamines, such as verapamil, and they act on calcium channels in the myocardium. It has a negatively inotropic effect and also slows AV conduction, lowering the heart rate and blood pressure. And then diltiazem has an intermediate effect between the two classes, which means it has cardiodepressant and vasodilatory effects. This is useful in angina and hypertension. Because of the negative inotropic effects of verapamil and diltiazem, it is important to remember that these should not be given with a beta blocker. Medical therapy for atherosclerotic disease has its limitations, and more definitive treatment can only be achieved by some form of revascularization, such as angioplasty, stenting, or coronary artery bypass grafting. However, not all patients will be suitable for the more invasive therapies, and therefore it is important to be familiar with commonly encountered medications for this disease process, which ultimately can be seen in all.